Assalamualaikum and good day everyone. We from Group 1 will be presenting about fever with petechial rash. So what is fever? So fever is the body normal response to fight infection. A person has a fever if the body temperature rises more than 37.5 degrees Celsius, and this is due to the increase in temperature regulation set point caused by pyrogen. So the mechanism of fever involve microorganisms which will induce inflammatory cells such as monocytes and macrophages. And these inflammatory cells will produce the pyrogenic cytokines such as interleukin-1, interleukin-6, tumor necrosis factor, and interferon. So this will cause the hypothalamic endothelium to produce prostaglandin E2. Therefore, prostaglandin E2 will rise the thermostatic set point in the thalamus. So body will try to conserve heat by vasoconstriction, shivering, and this will lead to fever.
Okay, so next we're going to look at the petechial rash. So what is petechial rash? So petechial rash is a pinpoint non-blanching spots that measures less than 2 mm in size. It usually affects the skin and mucous membranes.
So the causes of petechial rash such as prolonged straining, medication, infection, henoch in purpura, sepsis, viral hemorrhagic fever, blood and immune disorder, as well as diet. Okay, next we're going to look more in depth about dengue. So this is all the outline for dengue. Okay, so dengue is a vector-borne disease transmitted by the bite of an infected mosquito. So there are 4 serotypes of the virus that causes dengue, which are DEN 1, DEN 2, DEN 3, and DEN 4. So there are 2 vectors of dengue, which is Aedes aegypti and Aedes albopictus. However, Aedes aegypti is the primary vector.
So clinical manifestations of dengue usually begins abruptly and will be followed by 3 phases, which are febrile phase, critical phase, and recovery phase. So during the febrile phase, it usually lasts for 2 to 7 days and patient presents with sudden onset of high-grade fever accompanied by headache, mouth and nose bleeding, muscles and joint pains, vomiting, rash, and diarrhea. For the critical phase, it usually started after 3rd day of fever or around defervescence, which is when the temperature has lowered down. Critical phase usually lasts about 24 to 48 hours. So during the critical phase, most patients would clinically improve during this phase. However, certain patients will develop dengue with warning signs due to the severe plasma leakage as a result of increase in capillary permeability. So the clinical presentations of warning signs would be abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation such as pleural effusion, ascites, mucosal bleed, restlessness or lethargy, tender enlarged liver, and for the laboratory results, there will be increase in the hematocrit concurrent with rapid decrease in platelet. For the recovery phase, it usually occurs when the plasma leakage has stopped, thus leads to the reabsorption of the extravascular fluid. So during this phase, patient general well-being has improved and the hematocrit level starts to stabilize due to hemodilution. So next is about the skin manifestation that can be observed in dengue patient. So the initial rash in dengue fever will be transient flushing erythema of face that typically occurs shortly before or within the first 24 to 48 hours of the onset of symptoms, and it is thought to be the results of capillary dilatation. The second rash, which is maculopapular rash, usually occurs 3 to 6 days after the onset of fever. For the hemorrhagic manifestation on the skin, such as petechia, purpura, or ecchymosis with positive tourniquet test, are commonly seen in dengue hemorrhagic fever and dengue shock syndrome, but rarely seen in dengue fever. So during the recovery phase, subsequent to the critical phase where the plasma leakage has stopped, white island in a sea of red can be seen. So white island in a sea of red is the confluent erythematous or petechial rash with small areas of normal skin over the extremities, and it is thought to be due to the immune response to the virus.
Okay, so what are the criteria needed for the provisional diagnosis? So the first one is people who live in or travel to dengue endemic areas such as Africa or Southeast Asia. Second is patient who present with fever and 2 of the following, which is nausea or vomiting, rash, aches and pains, leukopenia, and any warning sign.
So patients who fulfill these criteria are suspected of dengue infection. However, to confirm the diagnosis, lab investigation must be done. Laboratory investigation. The full blood count in dengue patient will show leukopenia, thrombocytopenia and high hematocrit. Next is the dengue antigen and serology test by ELISA. So the non-structural protein 1 antigen, sensitivity is only up to day 5. For IgM antibody, sensitivity is only from day 5 up to day 90. And lastly, for the IgG antibody, it can only be detected after day 7. IgG antibody also helps to differentiate between the primary and secondary dengue infection. Next is a rapid combo test. So rapid combo test is used to detect NS1 antigen and antibody. So the test is only useful during the early phase, which is during the viremia, and the later stage which is when the antibodies has started to rise. The test is usually done at the bedsides where the results can be read in 15 to 20 minutes. For the reverse transcriptase PCR, it is used to detect viral RNA up to day 5 only. And lastly, for the viral isolation, it is not routinely done. Next is the management of dengue patient. So for the symptomatic treatment, acetaminophen may be used to treat fever and relieve other symptoms. Meanwhile, for the supportive treatment, such as fluid monitoring and therapy, maintain normal hematocrit and platelet level, as well as to monitor water intake and urine output. So all children with dengue infection who are treated as outpatients should have daily clinical and laboratory monitoring, such as full blood count, especially hematocrit and platelet count, daily fluid intake, and urine output. For the admission criteria, a patient with age less than 12 months, presence of warning signs, features of severe dengue, and presence of comorbidities. Next, we're going to look at the volume replacements for patients with severe dengue and compensated shock. So based on the top left algorithm, when patient presents with severe dengue and compensated shock, it is important to assess airway, breathing, obtain the baseline hematocrit, and insert the urinary catheter. So begin fluid resuscitations with normal salines or Ringer's lactate at 5 to 10 ml per kilogram over 1 hour for compensated shock. So if there is improvement, follow the next steps as written on this algorithm until the patient reaches stable hemodynamic, hematocrit, and general well-being. So once these have been achieved, the patient can be discharged. Lastly is the prevention of dengue. So to prevent mosquito bite, use insect repellent, wear long sleeve shirts and long pants to cover the arms and legs, and use screens on windows and doors to keep mosquito outdoors, and sleep under a mosquito net. So to prevent mosquito breeding site, manage and remove stagnant water once a week. So lastly is the vaccination or denguexia, but the vaccine was not suitable for people who had not previously been infected with the virus.
Now moving on to the meningococcal infection. Causative agent involved is Neisseria meningitidis. Neisseria meningitidis is a gram-negative diplococci that can cause acute serious life-threatening infection in children, although it is relatively less common in Malaysia. It is also fastidious and encapsulated. So there are 5 important serotypes that are associated with significant infection, which are A, B, C, Y, and W135. So the natural host is human, with mode of transmissions are via airborne droplets and close contact. And the portal of entry is nasopharynx. So the 2 common clinical outcomes of meningococcal disease are meningitis and meningococcemia. On the right hand side, you can see the gram-negative intracellular diplococci via gram staining. Now let us go into the clinical features of meningitis. The clinical features of meningitis can vary with age. For neonates, patient can present with poor feeding, irritability or lethargy, fever, apnea or seizure, vomiting, maternal GBS consultation, status and treatment. Upon physical examination, we can see bulging fontanelle, product C irritability, and high-pitched cry. Product C irritability is a sign of meningeal irritation when the child is quiet at rest, but cry when moved or comforted. Next, for infant, patient can present with seizure or fever, and upon physical examination, we can see neck stiffness and bulging fontanelle. For older children, patient can present with seizure, fever, changes in mental status, photophobia and rash. And upon physical examination, we can see positive chronic sign, positive Brudzinski sign, papilloedema, exanthems and joint involvement. Now for the clinical features of meningococcemia, The features are fever, fatigue, nausea and vomiting, chills, tachypnea, diarrhea, myalgia, arthralgia, hypotension and petechial or purpuric rash. For the petechial or purpuric rash, the characteristic lesions are non-blanching on palpation, irregular in size and outline and have a necrotic center. They also may progress to purpura fulminans. Purpura fulminans is a severe complication of meningococcal disease occurring approximately 15 to 25% of those with meningococemia. It is characterized by the acute onset of cutaneous hemorrhage and necrosis due to vascular thrombosis and disseminated intravascular coagulopathy. So the diagram on the upper right shows the purpuric skin lesion and purpura fulminans. For the diagnosis, the gold standard for diagnosis of meningococcal infection is the isolations of Neisseria meningitidis from a usually sterile body fluid such as blood and cerebrospinal fluid. Typically, cultures are done on the blood agar or chocolate agar. So on the blood agar, they will form grey, unpigmented, round, smooth, moist, glistening and convex with a clearly defined edge colony. Meanwhile, on chocolate agar, large colourless to grey, opaque colonies will form. Other than that, a presumptive diagnosis of meningococcal meningitis is often made by doing a gram stain where the result would be gram-negative, coffee bean-shaped diplococci. OCD test can also be performed and positive result will indicate meningococcal infection. Apart from that, serology tests such as latex agglutination test and PCR can also be performed to confirm or support the diagnosis. For lab tests, full blood count, urea, creatinine, and electrolytes and coagulation profile can also be done. This is the examples of the result of culture. So diagram on the right side is Neisseria meningitidis colonies on a blood agar which can be described as grey, unpigmented, round, smooth, moist, glistening, and convex with a clearly defined edge colony. Meanwhile, diagram on the left side is Neisseria meningitidis colonies on a chocolate agar that can be described as large, colourless to grey, opaque colonies. This is the examples of gram staining of Neisseria meningitidis that can be described as gram-negative coffee bean-shaped diplococci. On this slide, these are the features that you will get on lumbar puncture in terms of the cell count, protein, and glucose. For acute bacterial meningitis, glucose will be high around 100 to 50,000. Protein will be high as well, ranging from 1 to 5 gram per liter, and glucose will be low. In partially treated meningitis, glucose will be high and predominantly polymorphonuclear cell. Protein will be high, which is more than 1, and glucose will be low. In tuberculous meningitis, leukocyte is ranging from 10 to 500, where polymorphonuclear cell will be predominant and later followed by lymphocyte. Protein is ranging from 1 to 5 gram per liter and glucose range from 0 to 2. For fungal meningitis, leukocyte is only around 50 to 500, protein 0.5 to gram per liter and glucose can be normal or low. Early and appropriate antibiotic treatment markedly improve the outcome of meningococcal infection. So in cases of suspected bacterial meningitis, patients should be treated empirically to cover the most likely pathogen while waiting for the culture result. Usually, it consists of a third-generation cephalosporin such as cefotaximine or ceftriaxone. But if the organism is proven to be penicillin susceptible, the treatment can then be changed to penicillin. Regarding durations of therapy, it depends on the organism and the age of patient. For example, neonates might need to treat for 21 days, infant less than 3 months old can be treated for 14 days, and if more than 3 months, we can treat for 10 days. For older children, it depends on the organism, and usually Neisseria meningitidis need to be treated for 7 days. Meningococcal meningitis is well treated with penicillin G if the isolate is proven to be penicillin susceptible. So, penicillin can be used if the isolate has a penicillin minimum inhibitory concentration (MIC) less than 0.1 microgram per milliliter. If MIC is 0.1 to 1 microgram per milliliter, high-dose penicillin is effective, but a third-generation cephalosporin is more preferred. And penicillin can be administered intravenously or intramuscularly. Another antibiotic is third-generation cephalosporin, for example, ceftriaxone or cefotaxime. It has achieved a good CSF levels and have emerged as effective agents against gram-negative infection. And also, it is referable if isolate has penicillin MIC of 0.1 to 1 microgram per milliliter. However, none of the cephalosporin have any activity against the Listeria monocytogenes and enterococci. Therefore, a combination of ampicillin and a third-generation cephalosporin is required. Another antibiotic is chloramphenicol, which is recommended for patients with meningococcal meningitis who has significant hypersensitive to beta-lactam antimicrobial agents. Next, for adjunctive therapy, this includes corticosteroid therapy and supportive care to diminish complications and mortality. So, studies have shown that the use of dexamethasone has been associated with decreased inflammation, reduced cerebral edema, and intracranial pressure, and to lesser degrees of brain damage. Therefore, dexamethasone 0.1 mg per kilogram is given 4 times per day for 4 days and need to be given prior to antibiotics. But if we miss before the first dose of antibiotic, then it has to be given within 4 hours. Please remember to not give this after 12 hours of antibiotic, and also this is not indicated in patient that is less than 3 months. In supportive care, the temperature, pulse, blood pressure, and respiration need to be monitored 4 hourly and including the input or output. Other than that, kneel by mouth if unconscious. And next, judicious fluid management with careful monitoring. This is to ensure there is adequate circulating volume. And patient may also need more fluid if dehydrated. And lastly, observe for 24 hours after stopping therapy, and if there is no complication, patient can be discharged. Next, prevention of meningococcal infection is by antimicrobial chemoprophylaxis, which indicated in close contact and should be given as early as possible following the exposure. So the regimes include rifampicin, ciprofloxacin, and ceftriaxone. Another prevention step is by vaccination. So there are 2 types of vaccine, which are polysaccharide vaccine and conjugate meningococcal vaccine. For polysaccharide group A and C, it has 85 to 100% short-term efficacy for all the children. Group C vaccine is not effective for children less than 2 years old, and Group Y and W135 immunogenic only in children over 2 years old. So, this vaccine is only recommended in use for high-risk population. Other than that, conjugate meningococcal vaccine is highly immunogenic, although protective antibody titers are not long-lasting in your children. So, the adverse effect for this vaccine would be erythema and pain at the site of injection. This slide shows the comparisons of property between polysaccharide and conjugate vaccine in terms of T-cell dependent immune response, immune memory, lack of hyperresponsiveness, booster effect, persistence of protection, herd immunity, and reductions of nasopharyngeal carriage of bacteria, which all of these properties are pointed toward the conjugate vaccine, not the polysaccharide. These are our references, so that is all from Group 1. Thank you for listening.